Hello, everyone. Welcome to HEAL Courses, Health Equity and Advocacy Learning for Black people. I'm so excited and honored to be one of the speakers delivering presentations about all the different health conditions that impact us in a disproportionate manner. And there are loads. So you've had amazing delivery from our two other doctors, Module 1 and Module 2. And I'm about to deliver Module 3. So I'm Dr. Aziza Sesay, and this module has been written by the incredible Dr. Sharon Akinola. It's been summarized and just everything is well researched. So I'm really excited to deliver this. And well done again to Dr. Sho for putting this together. So let's get going. Women's health equity. We're going to be talking about infertility, PCOS, endometriosis, fibroids, perimenopause, and menopause. All right, so let's start. Now, when we talk about reproductive challenges, we as Black women face unique challenges, and this creates disparities that we face. So we face disparities in conditions like fibroids, PCOS, infertility. Unfortunately, it disproportionately affects us. And what will happen in this module is we're going to help empower advocacy for all of us and anybody watching to be able to advocate for their reproductive health. And we are going to address disparities so that we can ensure that we have better outcomes. And finally, we're hoping that there will be reproductive health equity for all of us Black women, because that is essential. Okay, so we're going to get right to it. Endometriosis. What is endometriosis? Before I start on every single condition, I want to make sure that you have the basics, okay? Anatomy. I want to quickly just run through the gynecological anatomy, and then I'll talk through the condition so it makes more sense. So this is the internal gynecological anatomy. This is a model of it. We have ovaries on either side, fallopian tubes, the uterus or the womb, the cervix, which is the neck of the womb, the vagina, which is on the inside, and on the outside, we have the vulva, and the vulva has multiple different parts. It has the mons pubis at the top, outer labia here, the inner labia is here, and then we have the vaginal opening here, so you can't see the vagina is on the inside, the urethral opening here, which is where the urine comes out. The clitoris is here, and it's only 10% of the whole clitoral complex that we see on the outside. It's usually covered and protected by the clitoral hood, and then we have the perineum, just at the bottom. Okay, now you know the gynecological anatomy. So when we talk about endometriosis, this is actually relatively common, affects about 10% of the population. We think probably much more, because unfortunately it's one that is underdiagnosed, misdiagnosed, and it takes up to 8 to 10 years before an individual is diagnosed with it. It's a chronic condition, which means that it's long-term. What happens is you have endometrial lining. So the inner aspect of the womb is known as the endometrium, okay? That's a bit of the womb that thickens and then sheds throughout the menstrual cycle. Now, the endometrial lining should only be present here on the inner aspect of the womb. What happens in endometriosis is you have tissue that's very, very similar to the endometrium in other areas of outside of the womb, okay? So it could be on the fallopian tubes, it could be on the ovaries, it could be on the bladder, which sits in front of the womb, it could be on the bowel, it could even go as far as the lungs, and it causes multiple symptoms, including severe pain. Now, pains include severe pelvic pain, so in the pelvis, irregular periods, very severe painful periods, painful sex. You may notice bladder changes, so pain when passing urine or needing to frequently pass urine, and that's because in front of the womb is the bladder, and if you have endometrial tissue there, then it can sort of stop the bladder from filling up enough, and that causes the urinary symptoms. If it's inside the bladder, it can cause bleeding in the urine. Similarly, if it's in the back, which is the bowel, it can cause constipation and pain when opening your bowels and so on. So complications of endometriosis include infertility. So what happens if, for instance, the endometrial tissue or endometrial-like tissues on the fallopian tube is what carries the egg that's produced by the ovaries down to meet the sperm in the womb. Now, if there are tissues that's blocking it, It's not going to meet the sperm, and that's where it can affect fertility, but also for a number of other reasons. It can cause cysts. So cysts are basically fluid-filled sacs in different aspects of the body, and it can cause adhesions. Adhesions means like scarring inside the body, and this is because the endometrial-like tissue works in a very similar manner as the endometrium, the endometrial lining. So it will thicken, and then in response to hormone, and then it will shed. But unlike in the womb, where it can shed straight down into the vagina, it has nowhere to go. So this is where scarring happens. And as I mentioned earlier, you can have bowel and bladder issues. It can cause chronic pain, which affects the individual's day-to-day life and their well-being. It's not supposed to be this way. You are not supposed to have extremely excruciatingly painful periods or symptoms that we've just mentioned and just get on with it. This needs to be checked out, and it could be endometriosis. Now, when we talk about endometriosis in Black women, unfortunately, we already know that it takes longer. It takes even longer in Black women, right, compared to their white counterparts by 2.5 years, right? So if I have already said that it can take 8 to 10 years, add 2.5 years to that. Imagine someone struggling with pain for that length of time. Unfortunately, we undergo surgery less often. And when we do get the operation, we have much more post-operation risks, so complications that happen because of the surgery. There's often also this misconception that endometriosis is rare in African heritage, when actually it may just be that Black women aren't listened to, and often our symptoms are dismissed. And we also suffer with other conditions that can cause similar symptoms, so it's pinned down to that. There are a number of factors, multitude of factors, which unfortunately cause the disparity that exists when it comes to endometriosis in us Black women. So because it's thought to be rare, it leads to delays in diagnosis, which means that treatment is suboptimal. It's not great, it's limited. And also because it's thought that it doesn't exist, or it doesn't really occur in Black women or African women, there's not that much research, again, in African women, but we'll talk about that with regards to research at some length in a minute. So treatment options for endometriosis: persons in pain, they should be given painkillers, and that could be anything from anti-inflammatory painkillers to like even the strongest painkillers that we call opiates, if it's really, really, really severe. And then there are hormonal therapies. So this can include hormonal tablets, so like the combined pill or the progesterone only pill to stabilize the hormone levels. We may be offered a coil that's put inside that is releasing hormones as well, and so on. There's also laparoscopic surgery. So when we say laparoscopic, that's keyhole surgery, where they look into the womb area and all around to see if there are any endometrial cysts around, and if there are, they try and remove it in that situation. So laparoscopy is what we call the gold standard for diagnosing endometriosis, because that's how we often can see it. However, if endometriotic tissue is not seen, or endometriotic-like tissue is not seen, it doesn't mean the person doesn't have the diagnosis. It may just be difficult to find, and we should still manage them appropriately. Lifestyle modifications have been proven to help. So eating healthily, exercising, those sort of things can make a difference. And also, because endometriosis can affect fertility, there are assisted reproductive technologies. So like IVF may be in use, and so on. Okay, next condition, polycystic ovarian syndrome. So when we say polycystic ovarian syndrome, poly meaning many, cystic meaning cysts, ovary meaning the ovary, and syndrome. Syndrome is basically where a condition has a multitude of symptoms, essentially, that then diagnoses the condition. Okay, so the name is a bit of a misnomer, because even though it says polycystic ovary syndrome, you don't need to have multiple cysts to be diagnosed as PCOS. Really, you have to fulfill what's called the Rotterdam criteria, 2 out of 3 of it. One being irregular period, the second being either having raised male hormone levels, or having symptoms that is associated with raised male hormone levels, like acne, what we call hirsutism, which is where you get hair in places that you wouldn't expect in a woman. So her chin, her face, her chest, her back, and so on, and acne. And thirdly, multiple cysts in the ovary. So as long as you have 2 out of 3, then you're diagnosed with PCOS. So PCOS is basically a condition in which there's a hormonal imbalance, right? You get the disruption of ovarian function, which means the ovaries are not functioning in the way that it's supposed to. So you're not getting the release in hormones properly, and also you're not getting the release in egg. So ovulation doesn't happen. Ovulation is when the egg is released. And obviously, if that happens, it's going to affect fertility. Symptoms for PCOS include irregular periods, excessive hair, acne, weight gain, and so on. It's said that PCOS is more severe in Black women. We have worsening symptoms. So hirsutism is much worse. As I said, hirsutism is where you have hair on the chin, on the face, chest, back, and so on, in places that you wouldn't really expect on a woman, thick hair. And then you may have what's called insulin resistance. So insulin resistance is where insulin is a hormone that's produced by a gland in the body to try and control the blood sugar levels. And in someone with PCOS, they are not as sensitive to the insulin. That's why we call it insulin resistance. And that leads to the multitude of hormonal imbalance and the symptoms that's associated with PCOS. It also causes obesity, makes it really difficult to lose weight. And unfortunately, PCOS is also associated with cardiovascular risks. All right. So it's so important that we understand the racial differences in PCOS. Okay, because we have what's called PCOS-related metabolic syndrome. This is basically, when we say metabolic syndrome, it's multiple different things that lead to a condition, and that includes having the high blood sugar levels, diabetes, having high cholesterol, obesity, and so on. So it is really vital that we try and prevent it as much as possible, manage the PCOS, particularly in Black population, because it can lead to untimely deaths, unfortunately, and complications. All right, so Black women often experience healthcare dismissal in general. Unfortunately, this is our reality, but it is really bad for PCOS symptoms as well. And often that's because of the weight stigma. So they just associate their being overweight to other factors rather than the PCOS. And they give weight-focused advice other than treatment that's available for PCOS. So there's no cure, but there are treatment options. Also, the higher levels of insulin in a Black woman, that causes more complications, as we say. We need more research to understand why. But in order that we improve the situation for Black women, we need more research. We need to address the fact that there are disparities that exist in the way that we are treated and the way that we are managed and the way that we are seen, really, if we are even seen. PCOS significantly impacts the body image of Black women. Because our symptoms are worse, it will cause more hair, weight gain, and so on. And this can lead to self-consciousness due to, as I say, the weight gain, the acne, the excess hair in places we don't want, and so on and so forth. And obviously that will have a significant impact on our mental health, mood, and so on. And it just leads to a vicious circle, doesn't it? So let's talk about menopause and perimenopause. So when we talk about menopause, menopause is when periods have stopped completely for 12 consecutive months. That's the end of reproductive life, and ovarian function is stopped. Perimenopause, peri means around, and menopause, as we say. So that's basically the period before the menopause has happened. It can go on for 4 to 8 years and so on. And the symptoms associated in, the symptoms that occur in perimenopause are very, very similar to the symptoms that occur in menopause. Now, menopause is difficult for a lot of people. The fact of the matter is it's even worse in Black women. We get menopause earlier. We have much intense perimenopausal symptoms that last longer and actually get worse with time, when usually it's supposed to get better. And often we don't have adequate hormonal treatment. And there's a multitude of reasons for this. But partly it's also because of the fact that the symptoms are not thought to be perimenopausal, because it's like, oh, well, you're too young. Actually, we're not too young. It can happen much earlier in our case. It's important that we address the disparities that exist so that we can have equitable care. Unfortunately, there is the lack of awareness in healthcare providers with regards to the realities that Black women face in perimenopause and menopause. There's a lot of dismissal that happens in our visits. There's also that historical mistrust, which then impacts Black woman's decision as to whether or not she's going to have hormonal replacement therapy, which is the first line treatment for menopause. So there's that reluctance of taking the medication based on historic mistrust. And then it's really important that we raise awareness about menopause, about the treatment, about perimenopause, about the fact that it's real and that it does exist in Black women, and much worse in our cases, usually, unfortunately. And it's also important that we build the trust so that we can have the crucial, better menopause care that we do deserve. All right, let's talk about fibroids. So fibroids are very, very, very common. It's said that at least 2/3 of women will develop fibroids by the age of 50. So they said 80% altogether, up to 80%. Black women are much, much more disproportionately affected. We're more likely to be diagnosed at a younger age. We have more fibroids, bigger fibroids, and also our symptoms are much worse. So fibroids are what we call benign, harmless growths that occur inside the muscle layer of the womb. And there are different types of fibroids. And depending on where they are, they have different symptoms, and they then affect the individuals depending on, as I say, where they are, how many there are, how big they are, and so on. Interestingly, though, 50% of women who have fibroids actually don't have symptoms, apparently. So you may have it and not even realize. Yes. Now, when we talk about the effects of fibroids in Black women, we have much more significant percentage being affected by between the ages of 18 and 30. And the number increases by 60% by the age of 45. So 60% of Black women by the age of 45 will have a fibroid. Now, risk factors for getting fibroids in Black women, there are suspicions as to why we are more likely to have fibroids, but there still needs to be a lot of research. We don't know for sure, but so far, what is thought to be the case is having earlier periods, obesity, stress, low vitamin D, genetic factors, but we're still not entirely sure what is happening in our case and why fibroids occur. We actually don't know why fibroids occur in general. In fact, most of these conditions, the cause is unclear. We don't know, and this is because when it comes to women's health and research, we only make up to about 1%, that excludes cancer. 1% of research, excluding cancer, is on women's health. That's how important we are in society. It's insane. This needs to change. Treatment options for fibroids include hormonal therapy. So as I said before, this could be combined pill, the progesterone-only pill. It could be having the hormonal coil as well, which can help with the symptoms. And then there might be minimal invasive procedures such as UFE, that stands for uterine fibroid embolization. This is when they block off the blood supply to the fibroid, which then stops it from growing. There's also something called endometrial ablation, which is where they basically burn the endometrial lining to stop the heaviness of bleeding, which often happens with fibroids. I hadn't mentioned some of the symptoms, but symptoms that you can get with fibroids include heavy, painful periods. Sometimes they can even be irregular. If the fibroid is pushing against the bladder, it can affect the bladder emptying, so you can get increased urination. If it's pushing against the bowel, it can cause constipation, and so on. It can cause bloating. It can make the abdomen so distended that some people actually look pregnant with fibroids. So there are so many symptoms that can be associated with fibroids. But as I say, some women have it and they have no symptoms at all. So there is no cure, but this is the treatment. The treatment includes the myomectomy, which is where they remove the fibroid itself. And then there's also the hysterectomy, which is where they remove the whole of the womb. There's also MRI-guided high-intensity focused ultrasound scan, which is basically where they they try and heat up and get rid of the fibroid through using magnetic waves, and it's quite fancy. And then there's radiation therapy, and also there's alternative and complementary therapy that work for some individuals. We need more research on that, but some people try acupuncture, herbal supplements, and dietary changes to help with their fibroids and the symptoms that they experience. Okay, let's talk about infertility. Unfortunately, because we are much more impacted by these conditions significantly, disproportionately, fibroids, PCOS, endometriosis, which affect fertility, then this is why we are more likely to suffer with infertility than white women. In fact, 2 times more likely. There's a lot of reasons behind this. It's multifactorial, but it includes things like cultural stigma. We don't actually come forward with our fertility problems until quite late. And it could be, as I say, because of the cultural stigma, lack of awareness, lack of access, affordability, limited insurance cover. We don't have that many donor options. There are not that many Black donor sperm or eggs. There's also the healthcare bias, which is a reality. And there's the discomfort in the predominantly white setting. When it comes to treatment, fertility treatment, it is predominantly a white setting, so that can impact people coming forward for treatment. And there's also that cultural sensitivity that we need to push for when it comes to infertility care to support Black women who are going through this. So, what can we do to empower Black women to advocate for their reproductive health needs? First of all, you're here, you've listened to this presentation, you know that there are disparities that exist. Please, please, please continue to share the knowledge, continue to educate and raise awareness, please. This can make such a massive difference, having community support where we can all be in a safe space together to have these conversations with one another so we feel seen and listened to, and also we can support each other with tips and what we've experienced and what, you know, support we've had and what's there, what's available. We need to try and improve access to care for Black women, help and make it more accessible for us. Also, we need to have culturally competent healthcare, be aware of some of the nuances that exist in our community, and this can then impact how we receive you and also how treatment can be met. Please stop dismissing us, believe us, listen to us. So an individual can have fibroids and endometriosis and adenomyosis at the same time, but these need to be diagnosed so that they can all be treated in the appropriate manner. We need more research. We need more data on us as Black women. I know we as individuals need to come forward as well. Yes, there has been the historic distrust and abuse when it comes to research in Black women, but we do need to start coming forward now. Things are in place. It's more robust. They can't do what they did before. So we do need to come forward. We need to have the data so that we know, so that we can figure out what's going on. Why is it that we are disproportionately affected? This wasn't mentioned earlier, but we also know that, you know, the impact of systemic racism and just the way that we've been treated in the past can impact our health. Stress impacts our health, which can in turn aggravate the symptoms that we may experience, and again, it can impact the conditions in which we have. We need more mental health support. We need more representation. I love that Dr. Show is doing this so that you can see that actually there are Black healthcare professionals in this space. But yes, we need more representation of the healthcare professional in leadership roles. We need more in campaigns and ads, and when it comes to health awareness, education forums and so on. We need better access to fertility services, and we need patient advocacy groups. We need more support, and we can change the narrative. We can do this together. So yeah, I hope that you found this useful. This is a whistle-stop tour of the common conditions that impact us disproportionately, unfortunately. But it is going to change. I believe it will change. I want you to remember that nobody knows your body better than you. You are literally the CEO of your body. If you feel like something is wrong, then don't allow anyone to dismiss you, please. If you need to get a second or a third or a fourth opinion, keep pushing. If you need to tell the doctor, look, this is what I think is going on, please can I have so and so and so, and this is why, then do it. If the doctor is saying no, ask them. You can ask them, please ask them. Why do you not think it's this? Okay, why do you think it's that? You know, and what treatment are you giving me? Why are you giving me this treatment? It's not being difficult. You are allowed to ask these questions. I'm not saying that you need to say it in an aggressive or angry manner. You can just say it the way that I've just said it. But why? Can you explain to me? That's your right as a human being, as a patient. Remember that. We will change the narrative. I'm so excited. Happy Black History Month. And please share this with family and friends. It could potentially save someone's life. Save their lives, because though these conditions don't necessarily kill individuals, it doesn't cause death, it can stop people from living. All right, thank you so much. These are the references. Thank you so much again to Dr. Sharon for amazing research. And I hope that you enjoyed this. Bye.